All right, good evening, everyone, and welcome to Wu University, our webinar, Advancement in IOLs, What's New with Multifocal, Toric, and Light Adjustable Lenses, with Dr. Amy Connor and Dr. Lee Peplinski. Thank you so much, guys, for being with us tonight. Super excited to learn from you, and I know our attendees as well, so thank you.
Thank you for having us.
Yeah. Next slide. I am your host, Dr. Elise Kramer, currently in Miami, Florida. What about you guys? Where are you located?
We're in San Antonio, Texas. We were just saying it's so hot here.
It's hot here too.
Yes.
We practiced together, now we're lecturing together.
Next slide. Thank you to RxSite for providing a medical education grant to support this event. Next slide. Just a few items before we get started here. For each hour of CE units, attendees must be online for a minimum of 50 minutes. For a COPE certificate, please fill out the survey link in the chat. Also, the survey link will appear when the webinar ends. CE certificates will be delivered by email and sent to ARBO with OE tracker numbers. And there will not be a QR code here, but you will receive your OE tracker, your CE, within 4 to 6 weeks by email. You can ask questions using the Zoom on-screen floating panel that you see circled here at the bottom. The chat, keep it for more logistic questions. If you have questions for the speakers, we're going to try to have some time at the end to answer those, so put those in the Q&A. Next slide. If you're using the mobile version tonight, you're going to see the Q&A at the top. If you want access to the chat, you'll click the 3 buttons there at the bottom to have more options, and you'll find the chat box there. Next slide. So I'm going to introduce our wonderful speaker, Dr. Amy Connor, who joined the Focal Point Vision team in June of 2020. She completed a postdoctoral residency in anterior segment disease and specialty contact lenses at the Texas Eye Research Technology Center at the University of Houston College of Optometry. Her doctorate in optometry with a therapeutic glaucoma entity came from the University of Incarnate World in San Antonio, Texas, with a master's in business and health administration and a bachelor's degree in biology from Virginia Tech. Dr. Connors is a newly branded Texan. She is active as a fellow of the American Academy of Optometry. Dr. Connor prides herself in patient relationships and loves to get to know her patients. Her specialties include pre- and post-operative exams, glaucoma, cataract evaluations, specialty contact lenses, keratoconus, dry eye disease, and diabetic eye exams. Thank you so much, Dr. Connor, for being here again. And these are your financial disclosures. And I will introduce our other speaker tonight, Dr. Lee Peplinski, who's a consultative optometrist with Focal Point Vision in San Antonio, Texas as well, with an emphasis in refractive cornea and cataract treatment, as well as glaucoma management. He has spent more than 30 years practicing medical and surgical eye care in a co-management setting. Dr. P has performed and taught laser eye procedures to his colleagues, residents, and interns for more than 10 years, and was the first OD worldwide to perform an intracameral implant for glaucoma management. That's so cool. Dr. Peplinski is a past member of the Kentucky Board of Optometric Examiners and a past president of the Kentucky Optometric Association. He has been active at both the state and federal levels as a voice to help shape healthcare policy and an advocate for optometry, especially within the Medical Carrier Advisory Committee process. He has published in national optometric journals and lectured both internationally as well as throughout the country at various state, regional, and national meetings. Dr. P has also designed and patented a device to aid in the dispensing of eye drops. From 2011 to 2020, Dr. Peplinski led teams on eye care mission trips to Belize, the Dominican Republic, Nigeria, Puerto Rico, and Peru. In 2018, he co-founded the Ret Pray Love Foundation to meet the physical and spiritual needs of those around the world through service and education. In 2024, RPLF merged into Fellowship of Christian Optometrists. Dr. Peplinski is a graduate of Ferris State University College of Optometry, having received highest honors. He then received his postgraduate training at the Bascom Palmer Eye Institute in Miami, Florida. That's close to me. And he is a board-certified diplomate of the American Board of Optometry and a fellow of the American Academy of Optometry. He has served as an adjunct faculty at several schools and colleges of optometry. And when he is not working, Dr. P enjoys traveling and spending time with his wife, 2 adult children, favorite son-in-law, and granddaughter. Thank you so much for being here, both of you. Looking forward to learning from you. And I will be back on later for some questions. Have fun and see you soon.
Fantastic.
Sure,
Take it away,
before we
Doc.
get started, I think you have to read your financial disclosures.
I am a speaker and a consultant for AbbVie and Allergan, Glaukos, and RxSight, who provided the grant for today's lecture. Thank you.
Yes, thank you. And I'm going to kind of take over. My portion is first, and we wanted to go over all financial relationships have been mitigated. And of course, you saw mine is none. And it feels like such an honor after you hear that wonderful bio from Dr. P to be in such great presence. But I feel honored every day to be in clinic with geniuses like this. I do get to practice with 5 other wonderful practitioners. And in our clinic, we do anterior segment disease, cataract, refractive, and it's so great to be in presence of people that can help me grow and learn as a practitioner. So for that, I'm going to take over for the first portion, and the first portion is about the multifocals and what's up and coming. And then Dr. P will take over, and I know you guys are all in the chat just to learn about the light adjustable lens, but you got to get through my portion first to get to his. So let's go ahead and get started. So for the first portion, we are going to give a little bit of a talk of astigmatism. We'll talk about femtosecond laser-assisted cataract surgery, or FLACS for short. We'll talk about Toric IOLs, ICLs, and then the different multifocals. And then the fun portion of my lecture is what's to come, what's on the pipeline, what's already come out. You'll see some videos of what we're trying, some new fun stuff. So I wanted to dive in with this picture here. This is actually our package that we offer at our cataract clinic. And of course, it doesn't have prices. But what I wanted to draw attention to is you'll see this very commonly. And when I talk to referring optometrists, it's a little confusing. So I did want to walk through it. The first portion here is our cataract package 1, and that means standard plain Jane lens, which your insurance is going to cover for. If your insurance covers it, most likely you're going to need glasses in the distance and glasses up close. So if you look here at our beautiful Riverwalk here in San Antonio, the person is after cataract surgery wearing glasses for distance and their phone. Now, if they decide to upgrade above and beyond what insurance will cover, then they can get a astigmatism package. And that's what we call our package 2 or 3. And you'll see in just a second when we choose just a regular FLACS, laser-assisted cataract surgery versus a Toric IOL. And those are our packages there. But if you look with those Torics, we're trying to get them to where they don't have to wear glasses in the distance, but they may have to wear some glasses for the reading and up close. And then when we move down to our package 4, this is our multifocal package, meaning if you look here, they can still see their phone and they can see across the way at that beautiful Riverwalk. So that's the multifocal. And then down here, we also offer the light adjustable lens. That also offers distance vision, and it also offers up close vision. And I'll talk to you about that in a second. This multifocal is going to be simultaneous vision, both eyes, distance, computer, and a little bit of up close. The LALs, and I'm not going to steal Dr. P's thunder, is only a monofocal lens. So one eye for distance, one eye for up close, but it has a little bit of a range. It is a monovision lens. So that's just a little bit about what we do. And I want to dive into astigmatism first. So the first thing I get lots of questions about are, why do I even want to tell my patients about laser-assisted cataract surgery? What is the benefits of it? And for short, it's femtosecond laser-assisted cataract surgery. So if you ever see FLACS written out, that just means that they had a laser during cataract surgery. So what I'm going to do here is explain to you exactly what the benefits are of having FLACS, or femtosecond laser-assisted cataract surgery. So the very first benefit is the cyclotorsion of the eye. Most people don't realize that when you lay down, your eyes go up and out, that bells, and then it torques a little bit. So the laser-assisted cataract surgery will help to compensate for that. The FLACS will also do corneal incisions, and there's a star there because not all surgeons use the femtosecond laser for the incisions. They might do them themselves. It also can do astigmatic keratotomies, or AKs, more commonly known. the capsulorhexis, and that's like a uniform capsulorhexis. And some of those capsulorhexis even come with a toric notch, which we love in this practice. And then the phacofragmentation is the big part. It helps to chop up the lens. So I want to show you a video here of exactly what you're looking at in our view when we are seeing it for surgery day. So this is actually a flax example. So what you're seeing here is it takes a 10-second or 10 different pictures of the eye to register it. And then the next thing that you'll be seeing is the eye as it's cyclotoric, torsion fixed. They are inputting the cylinder where the degrees are, and that's where the AKs are going to be. As they put the AKs, then they are going to place the lens on the eye. And here you can see that's the phacofragmentation. So you see the bubbles. That's the capsulorhexis, the round area there. And then it's making those AK incisions right at that axis like we were talking about. And I kind of want to show that to you again because a lot of people don't realize how quick it is. So again, there's the 10 different pictures of the eye to register. Okay, and now it's kind of rotating and figuring out where the eye is in space. They're inputting the degrees where the AKs are going to go. And then here, real quick, I don't want you to miss it. There's going to be a lens on the eye, the phacofragmentation, capsulorhexis, and then back to back, the AKs right after. So you can imagine how quickly that makes the surgery go. So it's super helpful to the patients for the healing, and it's super helpful in the surgeon's time frame. Okay. So for that first benefit of flax is a lot of people don't realize that there's a limit to it. The amount of astigmatism it can correct is only 0.5 to 1.5 diopters of corneal cyl. And that nomogram is from a surgeon's perspective. They will get a spit out lens that says you can either choose toric or you can choose the flax. And if they choose the toric, one of the reasons it'll push it that way is because the against the rule astigmatism usually can be only 1 diopter or less. With the rule can be 1.5 or less. And the reason it comes up with that nomogram is there's typically posterior corneal astigmatism of 0.5 against the rule. So if we have a patient that's right on the border, then it will probably do a toric lens instead of doing a flax instead. So again, I would know that the flax can only do 0.5 to 1.5 diopters of corneal cyl, or if they're on the border, know that the astigmatism is less that it can cover in the against the rule. So it only can cover up to 1 diopter of cyl and against the rule cyl, and it can cover up to 1.5 and with the rule cyl. All right. Next slide here. The neat thing about this is the cyclotorsion of the eye. As we lay down, the Bell's phenomena up and out, and the eye itself kind of rotates like a cookie monster. And as it rotates, it can be variant from any person, 2 degrees to 15 degrees. As optometrists, we know that if it's treating 4 diopters of cyl and they're 15 degrees off, they're going to be blurry. So the neat thing about the laser-assisted cataract surgery is it compensates for that. So if it moves up and out, it figures out where the eye is, so it can actually directly say, this is where the degree should be. Now, the alternative to that is actually taking a felt pen and using kind of like a measurement tool like this to figure out where the degree is and marking it. I don't know about you, but if I had cyl, I would want a laser to figure out where my cookie monster eyes went and put my toric implant in that I spent all this money on to make sure it's exactly right, instead of relying on just a felt tip pen. So that's just one option there, but that's one beautiful thing about the laser assisted cataract surgery. And there's those cookie monster eyes. And as we keep going, another benefit of flax is corneal incisions. And the corneal incisions that the flax can make is the machine is actually making, the laser making for us. There are 2 wounds that's going to make a true penetration for the paracentesis site, which is called the side port, the main wound, and the AKs, the arcuates like we're talking about. And here, the reason it was starred earlier in the lecture is some of the surgeons decide to turn this portion off and do their own incisions. And what I've heard from different surgeons is their preference because the laser makes it too perfect. So sometimes they have to suture it after to prevent any leakage like Seidel. I'm not a surgeon, but I've just heard that some turn off just because they like to do it themselves. The big thing here that you need to know are the main wound and the paracentesis are full thickness, and the AKs go down to maybe 80% thickness. So it's not a full, complete penetration in the AKs for the astigmatism. All right, so when you're looking at post-op care, I wanted to kind of break down the incisions that you can see from the flax. So the first one that you're going to see is the larger entrance port. And if you kind of look right here, that is the main port where the instruments will go. The smaller one is called a side port or paracentesis. In some states, you're allowed to burp. And if you do burp, it's always out of the smaller wound, so you do not have iris prolapse. And then the other two that you can see is like a dim gray, usually when you're looking under the microscope. Those are the AKs, and they should flatten the astigmatism. So they're there to relax the astigmatism so the patient won't have that long term. All right, and another beautiful benefit of this flax system is it typically makes a uniform capsulorhexis. So that circle in the center of the anterior capsule that the surgeon has to make to get to the actual crystalline lens, the laser is doing this beautiful circle for them. Now, with that, the good news about this is it's a uniform size. We've had questions before about anterior phimosis of the fibrosis of the capsule. Why does it happen? Is it smaller capsule? Is it bigger capsule? Is it the capsulorhexis? Is it the size of the capsulorhexis? And this takes the guesswork out of it. It makes a uniform capsulorhexis that the surgeon has no control over, and it's a proven size that works for most people. The beautiful thing here too is some of them laser assisted will have a notch here that you can see, and that notch will indicate where the toric lens should line up. So in a beautiful world, you see the notch on that front surface of the anterior capsule, and then behind it, you'll see the markings of the toric lens, and that means it's lined up. That would be the easiest case scenario of every one of our toric lenses. Now, another thing for the flax system is the phaco-fragmentation, and that just means the lens is getting fragmented. So the beautiful thing here is there is less energy needed. So the surgeon's putting less energy in the eye, meaning there's less inflammation left over, there's less edema, and it helps to get the lens out quicker. So the machine is actually slicing it to its more perfect fragmentation. So let's kind of dive into that. The regular standard cut for fragmentation is just the pizza pie, the 4 slices. So they have to go in and kind of divide and conquer each of these, and then they have to phaco or vacuum it out. Now, with optimized fragmentation, they go in and they make these little slivers here. And that was done so quick in that video that you just saw that the laser slices it up. So if you can imagine when they're going into divide and conquer, it's easier to scoop out each one than to kind of go scooping out a big pizza pie. And that's why there's less edema and quicker healing for the patients. I'm going to show you a video of both of these. The first one I want to show you is standard fragmentation. So if you can look at the left of the screen here, I kind of want to draw your attention to the kind of the X there, and that's the pizza pie. And there's no sound here, so I'm just going to let you see kind of the first divide and conquer, and then how it takes a little longer to get that piece of the crystalline lens out. So as you can see, he's gone into one of those incision sites we were talking about. And here you're going to see him use the phaco tip to do something they call divide and conquering, where they're going to split the lens a little bit to make it easier for them to vacuum out. And so retro illumination, you see the X there? That's the pizza pies he's going after. And you can see here, it's kind of tough. He has to use, more energy. It's a standard fragmentation. And he's going to manipulate the crystalline lens here. And as you can see, it's just going to be tough to get one piece of pie out. So I'm going to let you divide and conquer there. And then he's going to start kind of trying to break that pizza pie loose. And that's just the standard fragmentation there. We're going to let you watch for just a second longer so you can see how much longer it takes to actually get these pizza pies kind of separated. Okay. And so you kind of get the hint there that the standard is taking a little longer, more. You see that the piece of the crystal lens came out there. And now I'm going to show you the optimized fragmentation that's provided by the FLAC system for the phaco fragmentation. So it's kind of hard to see with retro, but there is the 4 slices still here, but there's these little slivers in between that you might be able to see on retro illumination in just a second. And it just makes it a little easier when they go into divide and conquer to take that little piece of pie out. All right, and here we get to the good stuff. So he's coming in to get the lens, and you can kind of already see that it's, I don't want to use the word looser, but easier to attain. It's not stuck to the bag so much because it has had that optimized fragmentation. And if you can imagine vacuuming a floor, this is kind of like what I say is he's just kind of vacuuming those little slivers out first. And it's gratifying in the sense that you can see it's getting shriveling up as he's going. And then in just a second, you'll actually be able to see one of those big pieces, just kind of the divide and conquer was easier. And then as he goes in with the phaco tip, you'll be able to see one part come out a little bit easier. And then we'll move on to the next slide after I show you that. So you can see here just barely, it's about to come in, and then the whole part breaks loose, and then the whole pizza pie will come with it. So with this, the goal is less energy in the eye, and that means less edema, less inflammation. And here comes that big piece. So it's kind of gratifying there. All right. And then instead of using the flax, we could just use a toric IOL. And that's exactly when the nomogram says, hey doc, hey surgeon, they have too much sil, switch over to an IOL that calculates for all of their astigmatism. If you have to do that, the parameters for the toric IOLs are 1.5 diopters of sil to 6.0 diopters of sil. And like I was saying, if your toric's off even a little bit, if you can imagine at 6 diopters of sil, they're going to be seeing shadowing and starburst. Now, a post-op pearl for that is if your patients are seeing starburst and they are seeing shadows and you're just scratching your head, what is going on? Go ahead and dilate them. And you can see that the axis on your topography, if you don't have that beautiful capsular rexus marking, should match the lens. So if the lens is supposed to be at 90 degrees, on the topo, you'll see it at 90 degrees. And then you look in the eye and the 3 dots should be at 90 degrees. So post-op pearl, that's one way to tell if the toric haptic is aligned. Now, a different way to look at it is if your surgeon does use the laser-assisted cataract surgery, some of them include this toric hash mark right on the capsular rexus. And let me kind of zoom in so you can see here that on the capsular rexus, it's beautiful. Right there, there's a notch, and then there's this implant right behind it that has those dots. And so you can see here it's aligned. If you don't have that, and you see that the capsular rexus doesn't have a notch, you can cheat and look at the topography, and you see that here, the topography, it's at 95 degrees where the steep meridian is. So you see here, 95 degrees, and then I look over here and it's exactly lined up at 95. Now, in this case, our patient had shadows and glare for a different reason, and that different reason is we dilated them for a PCO. However, they did not have shadows and glare because the toric was aligned, but we thought this was a great picture to show you both the PCO and the aligned toric here. All right, and now we're going to jump to ICLs, and that's the implantable Collamer lens. And I put here when laser refractive surgery will not cut it, kind of as a pun. And the reason it won't cut it is because we're not shaving off the cornea, we're actually putting a lens inside the eye. Now, why would we switch to an ICL? Why would refractive surgery not cut it? And the answer here is obvious. We know the first thing as optometrists we look at is too thin of corneas. Somebody comes in and they were just born with, I don't know, 300 microns of cornea thickness. You're like, okay, you can't have LASIK or PRK. Or if they've had prior surgery, they've had ectasia, irregular corneas, say they're lumpy, bumpy, Salzman, something, then you could switch to ICL. We've done a case where there has been a stromal scar and the PRK or the ICL might not have got through it. So they decided to do an ICL instead, and the patient loves it. Another reason is it could be outside of myopic parameters. And the reason I slow down and say myopic parameters is in the US, it's not approved. ICLs are not approved for hyperopic parameters yet. That might come down the pipeline. Other countries do have that, but we are a little behind the times and we have myopic parameters approved right now. And there's also toric ICLs that are also approved. Now let's dive into ICL and let's talk about when you choose this instead of a refractive lens exchange or like a toric IOL. And the parameters here for the ICL is from -3 up to 20. So one thing I did not realize is you cannot go lower than -3. I kind of thought ICL could do anything myopia, but if you have a run-of-the-mill -1 diopter sphere myope, sorry about your luck, you can't get an ICL. The cylinder that it actually can do is from -1 to -4 diopters of SIL. So it does have a wide range of SIL there. And one thing to look at before sending them in for an ICL evaluation is you need to make sure the anterior chamber depth is 2.8 to 3 millimeters. And the way that's measured is actually from the back of the cornea endothelium to the lens, the crystalline lens. And there's a lot of confusion if it's measured from the front of the cornea to the back. But the way they measure the anterior chamber depth is the back of the endothelium to the front of that crystalline lens. And it has to be a depth of 2.8 to 3 millimeters. And the neat thing about ICLs is they actually do come in different lengths, which I didn't know either until I started practicing here. The ICL comes in different parameters for lengths because it matters white to white, whereas IOLs are just 16 millimeters flat. You can get an 11 millimeter, 12 or 13 millimeter ICL just as it's more customizable to the patient, and it depends on their white to white. Now, this is just a picture of an OCT that shows an ICL, how it sits right in front of that natural crystalline lens. As we all know the anatomy, that it's sitting there and you actually don't have to remove the crystalline lens. So you don't have to do the refractive lens exchange if they're healthy enough. All right, and then like we said, don't forget the anterior chamber has to be a depth of 3 millimeters, 2.8 to 3 millimeters. And then the endothelial cell count, this was the one that a lot of people forget to check or can't check, and we can check here, is it has to have a bare minimum of 1,900. And the reason being is very few studies have shown that the ICLs can show a little bit of endothelial cell loss over time, and we want to prevent that. So obviously we don't want to throw them into Fuchs or any of that. So you want to use like a confocal or a specular to grade how many endothelial cells there are, and endothelial cell count at 1,900 as a bare minimum. Now, also, a lot of practitioners don't realize that in the past couple of years, ICLs have now gone away from having to have the YAG PIs on the iris. They actually have something called an ostium, and that just is the center of the lens is already fenestrated, and that helps with pupillary block. Now, in our practice, what we typically do is right eye, left eye, same day, and then same day, the optometrist will check pressures. There's much less risk of pupillary block now that the ostium is included in the lens, but it's still a risk. So you still have to check their pressure, make sure they're not nauseous and things like that. But just know that the new ICLs have the fenestration or the ostium in the center. What I included here is uniquely enough, our manifest refraction went from more myopic to even more myopic, with the vertex is usually more plus when we decided they picked the lens pick. And so I just thought that was kind of unique. This patient here was the one that had the scar, and his corneal thickness was actually 584, but he didn't qualify for like a LASIK or PRK. All right. And let's go to the next slide here. I did want to include this. A lot of people say, oh, I'm not going to do a laser-assisted cataract surgery because it doesn't help with my endothelial cell loss. Well, there's new studies showing that the endothelial cell loss is lessened than what it would be with just a standard cataract surgery. So standard cataract surgery is intuitively just going to have a little bit of endothelial cell loss. However, including the flax with this research article, it shows that you can even lessen it a little bit more if you decide to have that laser-assisted cataract surgery. All right, so I'm going to go ahead and jump to the multifocal optics. And the first part of it is kind of an optics lesson. So it's just kind of a fun thing to think about that we don't deal with every day, the optics of it. However, it's nice to know what's behind it if a patient asked. So we're going to jump into refractive versus diffractive. So turn your brains back on to optometry school and think about Snell's law. So Snell's law is the refraction of light. And the way that I can put it simply is it makes a single stop, one single spot that is going to be for distance or near, typically like a bifocal. The way that we can kind of separate that from a diffractive lens is when the wavelengths add together, they can either make bigger waves or they can make smaller waves. They can take away from each other. So those waveforms have to add together to get diffraction, and that's a range of spots, not just one particular. That range of spots is what we call a multifocal. So just to kind of show you a quick diagram, this kind of made more sense to me looking at it. As it bends light with refraction, you have one spot that it bends to, and that's going to be the distance, or one spot that it bends to for the near. One way to make this more clear to optometrists is to think of distance or near, center distance or center near contact lenses. So we all work in contact lenses and know that there's usually a center distance eye and a center near eye, and those are the concentric rings. So those concentric rings have a refractive power of center near to where it bends light to one particular spot on the retina, and that would be the distance for the center distance eye. For the center near eye, it bends it to fill one particular spot right in front of the retina, and that is the center near eye. And so, like I said, the refractive is one particular, the way it bends is just hits the retina at one particular spot. Now, some refractive examples, the way you can know it's a refractive lens is it will not have concentric rings typically. It just looks like a regular monofocal, but magically they can read. That means it has some refractive properties. And the biggest one that you're going to hear as kind of a buzzword is extended depth of focus. If they're just a plain lens with not rings on it, but they can read up close, that means that their range of focus or their depth of focus has to be there. So think of it kind of like a pinhole. And the way that these lens companies include these optics is by doing asphericity on the front or the back of the IOL. And that way the light can bend differently. This way, like I said, is known for not having concentric rings. The biggest one, the extended depth of focus that's out right now, is the light adjustable lens. Then there's the Eyhance that has asphericity on the front and back surface, which is of course proprietary to the company. The Vivity is known for non-diffractive wave front shaping. The crystalline lens, if you guys have seen it, is just a lens, but it has these, like they call it the Z shape. It is supposed to be accommodating, but it doesn't have those rings in it. And then there's the Array and the Rezoom are known for being what we call zonal progressives or multifocals. And the Array 1, those have different areas, almost like the center distance or center near contact lenses that have different specific spots it hits of the retina. But again, these are all refractive examples. Now, turning our brain on to that wave kind of where they kind of are constructive, where they add together, or where they are destructive, where the waves kind of take away from the interference. If you kind of look at this, you think of like a Fresnel prism, and you can see that the waves come in from the side, and the optics of it, they bring the waves together to add to a specific spot, and then you'll get different range of vision or multifocals. Now, here's a question. What examples are of the diffractive lenses? Think concentric rings, and everybody's starting to name all of them. And the answer is trick question. There are no such thing as just diffractive lenses. They have to be diffractive plus refractive, and I'll get to that right now, meaning the rings are what we call the diffractive portion of the IOL. The outside smooth portion, think of like if you have a 4 diopter myope and they get a 26 millimeter lens, that's the refractive, the smooth portion to make it hit the retina. Where they add the stuck-on rings on the front, that's the diffractive portion. So they're all kind of a combination of lenses. Now, some kind of examples of those, Restore is all smooth, and then it has these little bitty concentric rings in the center. The Symphony, the Synergy, Atlara, and then the buzzwords here are the Panoptics, which is known for being a trifocal. It kind of uses those multifocal optics to have different peaks at particular spaces. I believe it's Plano 1.25 and 1.75 where those waves end up hitting the retina. And then the Odyssey is the newest, and these are all kind of buzzwords because they have diffractive optics so they can see up close, but they're working to where they don't have the photopsias. I thought this was a neat picture I wanted to show you. And this picture shows if it's a monofocal with light coming in, you can see that it just hits at infinity and then it kind of dies off up close. So the light doesn't hit the retina. Now, if we look at refractive lenses, this is neat to look at in the sense that it's a hard stop. You see how it does not hit the retina? So there's a hard peak at infinity, a hard peak at it, like intermediate if they added it, and a hard peak of up close, but in between it's going to be very blurry. Diffractive optics, their goal is to make it nice and smooth all the way across so you don't have those areas of blur. And then the extended depth of focus lens is meant to have that asphericity so that you can see in the distance and a little bit up close. Intermediate, you're not going to probably get, near with an extended depth of focus lens. Now, not all diffraction is the same, and we know that. We have patients that say, man, I love this lens. And we have some patients that say, the halos at night are killing me. And the reason being is when they induce diffraction, the diffraction, if it doesn't have asphericity on the back of the lens, can cause halos and glare because it's taking all that wave and trying to add it, which makes scatter. So one of the lenses claims that their dysphotopsias, the halos and glare, is little to none. And then compared to other multifocals out there, you have lots of dysphotopsias. And the reason being is this lathing process. So if you look closely, some of the diffractive rings have these little itty bitty lines in it. This comes from the lathing where they cut it, and that can cause lots of light scatter. In the other type of lens, they've done to where they try to take the lathe and smooth it out, so there should be less dysphotopsias. Now, this is the fun portion of the lecture. This is the coming soon, and I will show you a video of one of the coming soon, so it's actually pretty neat to watch. And just to kind of go over this chart, I will not steal the thunder of the LAL+, but there is a LAL, and then the LAL+ has a little lenticular on it to help you to read. And that is approved, and it is a refractive style lens. There is an IC8 lens. We'll show you a picture of that in just a second. It's for a pinhole. The Clearview 3 is like a lined bifocal. And then there's a spiral lens on the market. And then there's the Gemini refractive capsule. And let's show you kind of dive into each of those. So the first one that we're talking about is the light adjustable lens. Dr. P has a full hour on this one. This is the buzzword out. Everyone's interested in it. And its newest baby is called the Light Adjustable Lens Plus. I don't think they were very original because it has a plus lenticule, and that center bubble at the center is supposed to add more extended depth of focus or more range for up close. The next one is called the IC8 pinhole, and this is exactly what it sounds like. It is a pinhole on the lens. They figured, hey, we tried a pinhole on the cornea a couple of years ago, and we could see it floating, and people didn't like it. Let's try it on an implant where people can't see it. So the bad news here is it does not dilate and constrict like normal pupils. So some people feel like they can read with it, but it sometimes just gets in their way. They can always see the rings when they're looking in the distance, but it's just something to think of because it does take away those dysphotopsias. All right, this is the exciting one that we're talking about. This one perplexed me, so I kind of want to dive into this one. This one looks like a bifocal to me. It is called a segmented refractive lens, and it's called the Clearview 3. When I first looked at it, I thought this was the distance portion, this was up close, and it had to be like a bifocal. This was just like a lined bifocal. Now, doing some research on this, there's some backstory to this. The near portion has to be decentered, so it's not directly like a flat segment. It's actually tilted. And the reason it's tilted is the reading portion has to be inferior nasal, and the distance portion has to be superior temporal. And that way, the segment kind of looks like as a diagonal, and we'll show you that in just a second. The other things behind this one is it's got a square plate. So as you can see here, you'll see a lot of new lenses coming out talking about square optics. And I had to pause the rep and say, I don't know why I care about square optics. And they said it's to prevent the formation of PCO early. So the square haptic here, or they can even do a square back surface. And what that is to hopefully prevent epithelial cells from marching to the back and forming a PCO. I don't know the truth of that, but that's the goal. And let me show you a video of this one. We actually implanted one. I didn't do it, but our surgeon implanted it yesterday. So it was perfect timing. And let's kind of dive in and show you the Clearview 3. So he has to make a bigger incision because the insertion pellet is bigger. The LAL pellets are bigger and the lens text pellets are bigger. So the incisions are bigger. And here he's putting it in. It has a marking where there's distance and near. And the near end has to be inferior nasal. So you're going to see that he has to realign it now because this is a left eye and it has to be rotated to where the near is down and in. And I'm just going to quickly show you that again, just because I think it's super interesting. And then I'm going to show you a post-op video of it. So you can see here, he puts it in. It's a bigger insertion. It's a bigger regular main port. And then the lens kind of comes out like a fruit roll up. And then he's kind of got to position it to where the distance and near are correct. So let me show you the post-op video. This is actually just a picture, I'm sorry. This is a left eye. And so you can imagine the nose is here. And when we were looking at it, I'm like, oh my gosh, it's got to split the pupil, right? It's got to be sideways. And it's actually always going to be typically at a diagonal to be inferior nasal. So when they're reading, they'll be able to see. And apparently the patient does not see this segmented line. The only thing that I can tell you is there's supposed to be a transition zone from distance to near, and this is supposed to be intermediate. However, the research that I looked online, very early research, the reason they came up with this is the company that makes the lathes for the multifocals decided to try their own hand at lenses. And they said all of these lenses have dysphotopsias, halos, and glare. Let's try to make a lens that doesn't have it. And they did, and in the research, the patients are still getting dysphotopsias, and that's because there's an image jump from distance to near, splitting their pupil. So we'll have more on that soon, but watch out for this new hot one on the market. This one absolutely boggles my mind optically wise. If somebody can explain it to me, maybe even from the company. I do not know how this does not make dysphotopsias and halos, but a new one on the market that's not approved is this spiral lens here. And what it does is it has different distance portions, near portions. To me, light would hit it and scatter everywhere. I just can tell you that this is up and coming. It's not approved yet. And the last thing I'm going to go over before we switch to LALs is the capsular ring. This is new in the world of ophthalmology. I don't think it's approved yet, but they're looking at it for lots of different reasons. So what this does is it goes in and expands the actual bag, the capsule bag, and then theoretically you can put whatever you want to in it. You can put an IOL in it. You can put virtual reality in it. They even said put wires in it to do diabetic checks and glaucoma checks. But when we tried the wires on contacts, it failed because, as we know, the eye is full of water and electricity doesn't like water. So they were thinking putting rings around the edges, but it's still bathed with aqueous. I'm not sure what the next steps are at this, but it is neat that it's out there that they're thinking about using the ring as the storage site and then putting something inside of it. So that's new and upcoming. And for here is my email address if you have any of those questions. We're going to slide over to Dr. P. He's going to take over, and this is what you're all here for. I know my lecture got in the way, but he's going to take over and talk to you about light adjustable lenses. There's my references if you care. And let's get situated. Just bear with us 1 second, please.
All right. Well, thank you, Dr. Connor. Thank you to Wu University, Dr. Kramer, for inviting us to speak on IOL technologies. And I will start by saying, you know, as the technologies develop in optometry in general, in ophthalmology in general, we as primary eye care providers have to keep up with it. We have to know what the options are for our patients and be able to be good advocates and make appropriate recommendations to our patients. So the whole purpose of today and the LAL portion is to give you what you ought to know so that you can at least speak intelligently to your patients about LALs, but you can also see where they might want to fit into your practice. So we're going to provide a little bit of the background in science of how they work. Hopefully we can identify some clinical situations where this technology may be actually the best option for you or your patients. I want to help you develop a confidence in knowing what your role as a co-managing optometrist would be, because there is a big role for that. And then finally realize how that technology can help produce some excellent outcomes in some patients that otherwise would have some challenges due to their clinical presentation. So if we can accomplish some or all of that, we'll consider this an evening well spent together.
Try clicking right there, maybe.
I think we already went over the basic proprietary and commercial support disclosures. So this we can move past. All right, so RX sight and light adjustable lens. Unfortunately, there's only one company that's doing a light adjustable product at this time, and it is proprietary. So when you try to get a lecture through COPE approval that only has one company talking about it, they kind of give a little bit of pushback. So I have to give a shout out to Dr. Connor, who worked very diligently toward getting this COPE approved. I know we don't have a QR code for you tonight, but the WooU people are going to get that. We got kind of some preliminary indications that that is forthcoming. But in order to achieve that, I've had to steer around some of the corporate indications within the slide, within the slide deck. But I do want to give you a little bit of a background, because this technology actually started to come to, I guess, just the possibility over 25 years ago. So it was in the late 90s that some polymer chemists came up with the concept that, hey, this might work in an implant lens, started to create the initial laboratory trials around 2000 and got it to where they could actually have clinical trials begin in 2007. So that was when things started to happen with a real live implant lens and patients. And it was around 2017 that things really changed. Not only did they achieve FDA approval, but they rebranded the company as RX Sight, and they were able to start to ramp up toward a commercial launch. That commercial launch went live in 2019, which, with a lot of things, wasn't the most optimal time to hit the market, because we all know what happened in 2020. The world shut down. Surgery for cataracts became more of an option, so those weren't considered medically necessary surgeries. So this technology didn't really start happening really over the past 3 to 4 years. And just earlier this year, the company came out with the LAL Plus product. So now we have a 2-lens platform within the light adjustable lenses. All right, and why is this important? Because as you know, we've all got patients that enjoy freedom from spectacle dependence. And so they are willing to seek surgical options to achieve this. And Dr. Connor did an excellent job of telling us about some of the other IOL technologies that are out there. But they also have some drawbacks, some pros, some cons. So what would happen if we can address some of those shortcomings and produce a product that can actually be fine-tuned to the patient? So with the LAL clinical trials, what they were able to achieve was almost 90% at 20/20 distance and J2 for reading with a binocular blended type of vision. And we're going to talk about blended vision. It's kind of a monovision concept, but a little bit more than that. All right, and the trials were mainly, and the whole lens technology was mainly designed to address some of the shortcomings with the other lens technologies that are out there, namely the dysphotopsias and the side effects that come from unresolved refractive error after cataract surgery, maybe some diffractive rings and some glare and some halos. Or how about contrast reduction that comes about as a result of diffractive optics? So if we can get a monofocal that delivers a full range of vision and avoids those complications, we've got an outstanding product. And the whole goal is happy patients with good quality vision and good quality of life as a result of that vision. So let's talk a little bit about the specifics of the lens itself. It is a biconvex silicone lens, but this silicone lens is embedded with some photoreactive polymers that are within the matrix of the lens itself. And that's where the adjustability comes from. And we're gonna talk about that. Because it's a silicone lens, it does have the PMMA haptics, so it's a 3-piece design. It can be put both in the bag, or if there's an issue during surgery, it can be placed in the sulcus. And that's actually I guess a bonus side effect of this, that if it goes in the sulcus, you don't have to recalculate what power of lens to put in, because you're going to be able to adjust it afterwards. It comes in normal parameters for power range, which is, and we're going to get to that. So let's talk about the photoreactive polymers. They respond to a certain wavelength of UV light. And if you're going to be taking the quiz at the end for your CE credit, this might be something that's important to pay attention to, but it's activated by UV light at about 365 nanometers. And that causes changes within the lens, which adjusts the focusing power of the lens. Kind of looks like this. You hit it with the UV light, and some of those macromers that are within the lens join together. And that creates a diffusion gradient that allows more of the macromers to move into the zone that was just polymerized, and that changes the shape and therefore the focusing power of the lens. And this is done in sessions that last usually about 30 seconds to around 2 minutes. And we're going to talk about how that gets staged after the surgery, but it's done in an incremental fashion so that we tend to try to move patients with stronger focusing toward a nearer target rather than having to push it the opposite direction. It's easier to steepen the lens than it is to try to flatten it if we overcorrect. And here are the parameters for that lens. Again, half diopter powers within the normal range for most of your IOL calculations. For the extreme myopes, the extreme hyperopes, we're going to come in 1 diopter steps. Now, again, with Fixed lenses, that can become a problem because you're not going to be able to dial that into, let's say, what your IOL calculator determined. But with an adjustable lens, we've got that adjustability. So as long as we're getting within the ballpark, we should be able to pick up the rest of that with the adjustments after the lens is placed. And typically, we're going to place an LAL lens in what we would consider the dominant eye. And again, for those of you that co-manage a lot of these patients, the more information you can provide your surgeon, the easier it's going to be for them with patient selection and lens selection. If you've had them in monovision previously with contact lenses, if they've had previous LASIK surgery that's produced a monovision result for them, knowing those things going into a consult, going into IOL selection, just makes it so much easier when they reach the surgical practice, because now we're talking to somebody who's familiar with the language, who's familiar with what we're trying to accomplish. And so traditional light adjustable lens is a monofocal. It's going to get you a pretty good distance vision with a little bit of intermediate range, but with the LAL Plus, it produces an aspheric button on the front surface that is allowed to give you a little bit more of that defocus curve and a little bit more intermediate without having to do any adjustments. So a little bit of that eat-off effect with the LAL Plus. And here's what the RX Sight folks have put out as the defocus curve. And again, you can see that at Plano, we've got excellent distance vision, but as we get a little bit off from Plano and get to that intermediate range, we're getting a little bit more area under the curve with the Plus and the aspheric design. So think of that as giving you a little bit more of an intermediate bump. Now, we mentioned that ultimately we're aiming for kind of a blended vision, but this is something that's customizable and can be individually personalized to the needs of the patient. And rather than having to figure that all out ahead of the game, we can actually demonstrate it and let the patient test drive it and then come back and adjust and modify after the fact. But what the company found in their post-market analysis, and this was through a registry that involved 84 centers and close to 1,000 eyes, 944 eyes, after this was FDA approved, and they did the analytics and they found out that the vast majority of patients, 84% of the patients, wanted to be mini monovision or less. So we're going to say within just a diopter and a half of anisometropia from the distance eye to the near eye, but that with that mini monovision, they were able to still see, remember we said almost 92% at J2 and 87% at distance. Now, of that, the majority of patients landed around a diopter to a diopter and a quarter of that near vision power for the near eye. And even 16% said, you know what, we would just rather have bilateral distance vision, and we're willing to wear some reading glasses for the close work. And this is where this gets to be tuned in specifically to your individual patient and their needs. I've even had a few patients that thought they wanted one thing, and once we got into the adjustments, they realized, gosh, that's not working for me. Can we move this around and reshift and re-aim what our target's going to be? And that gives, this lens gives you the flexibility to do that. So that's, I think, what sets it apart. Now, for the distance results, this is the distance eye, regardless of what the target was. So this could be target of actual emetropia and 0. And if we're targeting that, we're within a half diopter on close to 94% and within a diopter on about 99% of the eyes. So you can pretty much assure that you're going to have excellent distance acuity without the glare and halos. But some of the patients will actually opt to maybe have a -1/4 or a -1/2, especially if they're shooters. And so you can cheat that distance eye in just a little bit without giving up too much of the distance acuity, and give them the ability to see their sights and still see downrange. So we've had a few patients that don't actually target emmetropia in their distance eye. For the monocular acuity in that subset, again, 80% or more were 20/20, and by the time you get up to 20/30 or 20/40, you're pushing even higher values. And this was with all patients, whether they had previous surgery or not. And we're going to see that some of the challenges that get into IOL calculation and being able to offer that extra clear postoperative vision are affected by corneal parameters such as prior corneal surgery, corneal irregularities from scars or dystrophies. And so patients who are motivated to be glasses independent, many of them have had LASIK surgery, RK surgery, PRK surgery. And I will tell you, some of the happiest LAL patients are those post-refractive, because maybe we don't want to put a diffractive multifocal in them, but they still don't want to have to rely on reading vision. And now if we're trying to set a distance lens, how can we make sure we're going to get that exactly toward emmetropia? And if we're off, what do we do? Do we come back and have to do more laser over the top? With the LAL lens, those are moot questions, because we can usually adjust the implant and get that happy outcome. But what this slide is showing you is that whether they've had previous corneal refractive surgery or not, the outcomes are essentially the same as with the virgin eyes. And this is within that 944 patient database. All right, so what are we trying to address? We've all had patients that come back after cataract surgery with residual refractive error, and especially if they're that type A person that is expecting perfection. I know none of you probably have seen those folks, but when they hit your chair, they can be 20/25 or even 20/20 minus and just be miserable, and they make your day miserable. So residual refractive error can be a significant issue. Residual astigmatism. I know Dr. Connor mentioned that a lot of times we'll use LRIs or even the femto laser to address lower amounts of astigmatism. But what happens if it doesn't get it all? Let's say they had 3/4 or a diopter beforehand, and you knock it down to a half diopter. That patient may still be having some minor dysphotopsias as a result of that. Certainly, if they don't get a multifocal or try to address intermediate vision with a different method, they're going to have poor near vision. They're going to have a reliance on some reading glasses afterwards. What if we could address that through the LAL option and get it there without getting some of the glare and the halos and the other contrast related issues that some of our diffractive lens options provide? These are the patients that we want to start thinking about setting up for LAL. So rather than trying to navigate this challenge of preoperative measurements and maybe measure once, measure twice, measure 3 times, and then make our best swag, a strategic wild guess to get a result that we are then stuck with. What if we can put something in and then be able to modify and adjust it afterwards? That seems like a much happier result for both the surgeons and for the patients. And I know our surgeons seem to sleep better and sweat less in their preoperative calculations. All right, so what are those things that can give us the refractive surprise afterwards? We talked about kind of the corneal power challenges of being able to figure out what that corneal power is going to be, especially if there are some irregularities, because we've got topographies that measure it one way, we've got keratometries that measure it another way, and sometimes if the cornea is in a weird prolate or irregular shape, we're not going to get the same measurement depending on what part of the cornea is involved. And so yeah, that becomes a predictive error problem. But probably even more of a predictive error problem is where that lens is going to fit in the eye after the surgery, the effective IOL position. The biometers are pretty good at trying to measure anterior chamber depth and white to white, which may help decide how big that bag is and how much it's going to allow those haptics to stretch and where that lens is going to position. But if you're looking at a high-powered lens that's even a fraction of a millimeter fore or aft of where you predict it's going to be, the refractive outcome on that patient is going to be affected by that. And even though we can do femto-assisted surgeries and get a perfect rhexis and expect that lens to center and position exactly where we want it to, there's still a variable there. And that variable is where we can often get the surprises. And then the third source of some of those refractive surprises is axial length. We're pretty good with the optical biometers now on nailing that down. But what happens when the cataract's dense enough and you can't use an optical biometry? You have to resort maybe to an ultrasound. There's going to be a little bit more forgiveness in terms of what that absolute is. And so all three of these things coming together, we can run calculation after calculation after calculation and still be off. We're going to give it our best guess, but once we make that selection, that's what the patient's stuck with if it's a fixed lens. If it's an adjustable lens, we can make up for some of those calculations. One of my surgeons likes to say the physics is pretty predictable. It's the biology that's the variable. And I think those are three cases or three areas where the biology can be very variable. So again, those are the sources of the suboptimal outcomes. And we can have happy patients, we can have satisfied patients, and unfortunately, sometimes we get the unsatisfied patients. What happens if we can fine-tune that, if we can tailor it right to what the patient wants, rather than picking small, medium, and large and trying to find the one that fits best for that individual patient? What happens if we can put it on them and then adjust it and trim a little bit here and adjust a little bit there and get it to where it's a finely tailored fit? That's the benefit of the light adjustable lens. This was a post hoc analysis of toric lenses with a fixed optic, and it showed that of the refractive errors afterwards, clearly 35% were based on IOL position. So again, that is the biggest challenge that we have. And unfortunately, we don't have a way to conquer that with fixed lenses. So how do we take the pressure away? Rather than having to make a high stakes decision off of a bunch of pre-surgical measurements, we do the adjustments after the surgery and can achieve a much higher rate of precision. So here's how that works. And this is where co-management becomes a significant portion of the role that you guys will play. So the surgery takes place. During the first 17 to 21 days, that's normal post-op recovery. So this is where you're going to be involved with making sure at the one-day visit, at the one-week visit, that everything's healing up well, that their vision's progressing and their refraction is stabilizing, because we don't want to try to adjust or treat something that's not stable, right? We want to make sure that that refraction is something that has finally set in. And usually that's going to be about 3 weeks after the initial surgery. And then finally, we want to optimize that ocular surface. Just like with any of our post-surgical patients, we know they're going to get the best outcomes if their dry eyes managed, if their cornea is fully hydrated, if all of those issues are taken care of. They're going to come back to the surgical practice usually about 3 weeks, get an adjustment, and somewhere between 3 to 7 days later, or patient specific, we're going to keep repeating that process, letting them test drive their vision, bringing them back, readdressing what their goals and their outcomes have been, maybe making some adjustments in our goals, maybe making some adjustments in the lens, lather, rinse, repeat until we're happy, the patients are happy, and then we've got a couple of lock-in treatments. All right, now while we're doing that, while you're seeing the patient during those interval visits, while we're seeing the patients through the adjustment visits, we're reminding them, and I guess we haven't addressed this yet, but we're about to, that wearing a special set of sunglasses outdoors that are provided to the patient with the surgery that blocks that 365 nanometer UV light when they're outdoors. The lens has a filter on it that protects them from stray light indoors. So artificial illumination from any of the bulbs that we see interiorly are not a problem. So they don't need to wear protective eyewear per se indoors. I usually advise if they have a large bank of windows and we don't know what kind of UV filter the glass has on it, if they're getting a lot of exterior solar light, they may want to wear a clear pair of UV protecting lenses indoors. But when they're outdoors, we want them to wear that so that we don't induce an unwanted adjustment in the lens. Haven't seen it happen yet. Don't want my patients to be the first ones to encounter that. So we're checking and we're reminding and we're maintaining compliance with that. Again, we're checking to make sure the eye is healing, that their ocular surface is healthy, and that things are stabilizing. And again, this is where you guys can start to have that early discussion. How's your distance vision? How about your near vision? Where are you struggling? What's the goal going to be when we get to the adjustments? And the more information that you share with us, the more we can hit the ground running when they come back for that first adjustment. Here are the glasses that are provided to the patient. They're pretty decent looking, but they do offer that UV protection both outdoors and indoors if necessary. And they actually have a third clear pair that has a little 150 ad on the bottom, because for those first few weeks, if both eyes are still set for distance, they're going to need a little bit of help temporarily, at least until we start adjusting that near eye in. And we usually tell them it's about 4 to 8 weeks. I know it says 5 to 6 weeks on here, but depending on how you space out those adjustment visits, this can be a stretch until we get them to the very end, and we want them to be wearing this protection all the way till the final lock-in. All right, here's what that timeline looks like. So again, surgery here, followed by the standard post-op at your office. This is the co-managed time of 17 days to 3 weeks. They come back in and we have the first adjustment visit. Then usually 3 to 7 days later, they get to test drive over that time, see how their vision's working to meet their needs. They come back in, they say, "Doc, I'm doing great. I love it." And if we agree, we may start the lock-in treatments right there. If they say, "You know what, Doc, my distance vision, I'm loving it, but I think I want the near vision to be a little bit stronger," we can trial frame them. Sometimes we'll take a pause. We may even put a temporary contact lens. Are you sure? Do we want to do that? And once we make that decision, we can do a second adjustment. Bring them back a few days later, have that same discussion. Typically, after 2, maybe 3 adjustments, we're going to get to our lock-in treatments. And the lock-in process is exactly the same as the adjustment process in terms of what patient flow is. The only difference is the LDD device, the light delivery device for the adjustments, provides a little bit different array of light during those treatments. So at each of those visits, we're going to check what their vision is, what their refractive error is. They may be, within that quarter or half diopter and they're 20 happy, then we're 20 happy. If they're a half diopter off and they're miserable and they're complaining about problems, we've got the ability to adjust that. We're going to talk about intermediate versus near. And again, with the depth of focus effect that this lens gives, you don't need to typically do a full monovision result. Usually with about a diopter, maybe up to a diopter and a half, you're going to get great dashboard and computer vision, but it's also going to give them that bump that gives them cell phone vision and pretty much most of the near vision that they need. And I always tell them, our goal is not to make you 100% glasses free. I want you to be 90 to 95% glasses free for most of your typical day. If you're going to sit down and read a novel and you like to hold it really close, if you're going to do some sewing or needlepoint or tie some fishing lures that require super fine, close vision, we're going to expect that you want to have some reading glasses for that. And again, it's setting their expectations to deliver, a happy result. Overpromise, underpromise, overdeliver, right? And of course, that depends on making sure that we've got their monovision set up the right way. If they've had monovision from LASIK surgery or contact lenses, that's what we're aiming for. But some of these patients are monovision or blended vision naive. So now we've got to figure that out. And guess what? If their cataract was worse in their dominant eye, that may be harder to predict because there's really not a clear defined test to tell us which eye they're going to prefer for distance. So again, knowing that from your practice, if they've been your patient for years, knowing which eye that should be, that helps us with those decisions. Usually what I coach them up as they're going through the test drive process is to trombone their near vision. Literally take what they're trying to see and move it in and out like a trombone to find that sweet spot. And if that sweet spot is typically in that 12 to 16-inch range and they're happy seeing their computer out here and they can still see it at that range, that's the near to intermediate that we're aiming for. So all of this takes time. And I guess that's probably one thing that I haven't emphasized enough is in patient selection, we want to make sure we've got a patient that's willing to invest the time to get the better outcomes. Because if they're not going to be available for the follow-ups, if they're not willing to wear the sunglasses for that extra several weeks, if they're not willing to come back in and get the adjustments as we go, that's going to create a problem. All right, so again, here's how, just a review of how the summary works. That the active shield is present to block UV light, stray UV from indoors. So it's protecting the lens from just normal light from producing any polymerization of these macromers within the lens. Once we shine the LDD to them, the light activates the polymers and they start to produce this diffusion process within the lens that changes the shape of the lens and thereby changes the refracting power. Once we get to the power that we want, we shine a different array of light that then locks the existing macromers in place so that there's no more diffusion allowed. And once they get through that second lock-in treatment, then they can be exposed to that 365 and it's not going to change the lens. And I've had patients ask me, well, what happens if I decide a year from now or 2 years from now that I want to get a different adjustment? And we make a point to tell them, nope, that's not an option. Once these things are set, that's what you're set with for the long haul. All right, so again, we tell them plan on 6 to 8 weeks. If they don't need all 3 adjustments, if they only need 1 or 2 before the lock-in treatments, that may be a little bit shorter, but it's always better to shorten that up and make them happy because they got through it a little bit faster than to keep dragging it out and dragging it out and dragging it out. And I guess that may be one of the other potential downsides is the longer this goes, do the patients kind of get more critical about their vision? Do they get more critical about some of the finer nuances? We've all had patients that have been hypercritical even when we think that they're doing fine. So yeah, just be aware that you're still going to see some of those patients even when they are 20/20. All right. So what's the roadmap? The roadmap at these visits is, again, working them up, getting their acuity, getting their manifest refraction, customizing the plan. I guess that's also an important reminder at the adjustment visits, the patients are dilated each time. And typically this dilation is not just 1 drop of tropicamide or 1 drop of neo. They're going to get multiple drops because we want to expose as much of that lens as possible. If we can get the entire optic exposed to the light delivery device, that is best. If we can't, if they just have a small pupil and they're a difficult dilator, we'll settle for being able to see the very tip little end of each of the haptics. That's an adequate dilation to get the adjustment done. I've had a few instances of patients who had very challenging pupils that we've even put a contact lens soaked in a mydriatic to try to get that pupil big enough, especially for the lock-in treatments. So they have to be willing to be dilated at each of those visits. And then once their pupil's dilated, we get them down to the delivery device. Again, shining a light for 30 seconds to 2 minutes is the typical treatment. And the locking treatments are the same amount of time, 95 seconds for the first lock and about 2 minutes and 5 seconds for the final lock. So that's the process. And I just want to walk through a real live case example with you of kind of a patient that was a perfect candidate for this for a number of reasons that will become apparent, but also became a perfect advocate because just the life-changing result that she got. She volunteered to, post reviews and even do testimonials if we needed it. I don't think we've taken her up on that yet, but I know she would be a great patient for that. So 56-year-old female who has a long history of very high myopia, as you can see, with a significant amount of astigmatism as well. Presented to our office for a cataract evaluation. And yes, her vision was kind of reduced from the cataracts, and she did have clinically significant cataracts. But in her history, she happened to mention, kind of more offhanded than anything, that she had sought refractive surgery years prior, but was told that she wasn't a candidate because something was wrong with her eyes. So immediately our ears perk up, but it became pretty obvious what that something was when we saw her topography results, because she has a very asymmetric bow tie or hourglass image, which is significantly steepened inferiorly, probably represents a little bit of ectasia, very thin central corneas, around 480 microns in each eye. So with a diagnosis of form-fruste keratoconus, this became a challenge. How do you determine what type of lens you would want to put in this patient if you wanted to put in a toric? Because we're looking at about 2 or just under 2 diopters of corneal cylinder, but it's asymmetric. So which part of the parameter do you pick? And her overall refractive cylinder was actually a little bit more than that. So I think picking a toric for this type of patient would be a challenge. You might be able to make a wild guess and get pretty close, but you're probably going to be left with a little bit of residual refractive error. So this patient opted for a LAL and ultimately with a monovision target. Now, at this time, our practice was choosing to set both eyes initially more at distance, and then we walk the near eye in. Again, easier to adjust it in a little bit at a time rather than make it too strong and have to push it back out. So this patient saw her co-managing optometrist for the first couple of post-op visits. And by 3 weeks or day 22 after surgery, came in for her first adjustment. And, you know, she was already ecstatic. You can imagine coming from -12 and being able to see 20/30 during those first few weeks. She was already quite pleased. And I do apologize that our refractions are in ophthalmology language. We're refracting in plus cylinder form. But that just makes it easier for us to identify what axis we're dealing with. But you can make the conversions if you'd like to. So her vision wasn't bad, but again, during that time, it wasn't perfect. And we do make a point to tell the patients exactly that. You know, you're going to have pretty good vision right after the surgery, but you're not going to get the really good vision till we start working through the adjustment process. So after we had pretty good confidence in her residual astigmatism, we set a treatment plan of aiming for plano in her dominant right eye and start out with that -1 number for the left eye. So that was the treatment. And she came back 1 week later. So now we're at day 29. And she says, you know what, doc, things are better, but I'd really like to make my near vision just a little bit stronger still. So notice the distance vision kind of flip-flop. Now she's finally getting that better distance vision in the right eye, which is what we're looking for. And the left eye, the distance is still about 20/40, but we're now starting to get that J2 vision up close, albeit with a little bit of effort. So her residual refractive error, we cut the cylinder about in half in the right eye, and we are getting pretty close in the left eye to our target. But I didn't think that this cylinder was the entire problem, that she was wanting a little bit stronger near vision. And knowing that she came from -12, I wasn't going to try to aim for here, but I thought she would tolerate a little bit more for the close. So we bumped the near target up to a 150. And that was the next treatment that she got at the second visit. Now she comes back a week later, day 35, for her third adjustment visit. And she says, you know what? I like my vision. And she's 20/20 at distance. She's 20/20 at near. She's right on target at distance and pretty darn close at near. But again, with that 20 happy vision. And so we decided to do the lock treatment, do lock number 1. And came back a week later, still happy. And I'll tell you, things don't really change between the first lock and the second lock. I'm going to say the first lock probably does 80 to 90% of what we want it to. So vision's almost always been exactly stable. And if it's not, I'm probably looking more toward an ocular surface issue, not a refractive shift issue. A quarter diopter of astigmatism, I'm going to blame my refraction on that. It might have been essentially the same. But what we have here is a patient that had a very happy final result. So I hope that gives you a great example of when the LAL can be used as a potential platform for a challenging patient. And what I would also say is, if we've been able to share with you a little bit about how the science behind light adjustable lenses works, helped you identify a few situations where you might want to get some patients involved with this, made you a little bit more comfortable answering questions and co-managing some of the situations that may arise.